So now we'll discuss about the complete renal failure condition where now kidney function is completely lost, and now we go further with the dialysis options, or what do you suggest in patients with complete renal failure?
So the best form of treatment for kidney patients is transplant. Whenever we talk, the best option is of course kidney transplant, which will be either live or cadaver related, but most of the patients will opt for dialysis. Now, dialysis can also be of two types, that is hemodialysis and peritoneal dialysis, out of which the most common that we know of is hemodialysis. So I'll talk about that first. Hemodialysis is a type of treatment where a person is connected to a machine. So we have to have one axis where the blood will go from the patient slowly into the machine. It will get filtered, and at the same time it will keep coming back. So this is what we call as hemodialysis, which happens, we have hemodialysis centers, we have machines for that, and we need to have an access for this. Now, access means from where the blood has to come from the body. So it can be catheters or it can be fistula. So when we advise treatment to a patient, dialysis to a patient, stage 5 patient, mostly they are not prepared for dialysis. So we generally go for temporary catheters in these patients, which is preferable site is in the neck. So either right side or left side will have a certain vein, internal jugular vein, where we put it. So, but since, as the name also suggests, it's a temporary catheter, it cannot stay for more than 4 to 6 weeks. So, and there is a high risk of infection with these catheters. So we definitely ask the patient to go for something else which is permanent, which is more permanent way of dialysis. So either it is a fistula or it's a permanent catheter.
So for perm cath, we have different access sites, but what is the time frame where you should change it to from temporary catheter to perm cath? So how soon patient should get a perm cath or a fistula created?
So again, there are two sets of patients. One is the set of patient who has been following with a nephrologist and he is on stage 5, not on dialysis. So such patients, we already prepare them for dialysis. So we tell them, okay, now the situation has come that you may require dialysis in future. So either we ask them to go for fistula, preemptive fistula creation, or so in that evaluation, we get to know how the vessels of the patient are. So certain diabetic patient, obese patient, females, they may not have good veins for fistula creation. So in such patients, I suggest my patient to directly go for a permanent catheter at the time of when we know that now the dialysis is needed. So these patients I do not offer temporary, because putting a temporary, then after 4 to 6 weeks shifting to a permanent. So these are the ones that require permanent catheter at the go. But the other set of patients, like those who have come in emergency to me and I have to put a temporary catheter, so I give them a time frame in 4 to 6 weeks, we need to create a fistula. I will evaluate them, how are their blood vessels, and if as early as possible, I'll go for fistula. So fistula can be done in the hand, at the wrist, at the elbow, brachiocephalic. So those are the areas where we can do, if not possible. So then we tell the patient that as early as possible you go for permanent, because you will require it. The more the temporary catheter stays, the more the risk of infection and worsening of the overall health of the patient. So such patients will require permanent catheter much early than a normal patient.
Yeah, so being an intervention radiologist, we put perm cath, but it's kind of misnomer that it's not permanent. Like it is called as long duration catheter or a tunnel dialysis catheter. I have seen patient coming with perm cath for 4 to 6 years also, and sometimes the perm cath gets infected within 1 month also. So the reason is whatever good quality of perm cath we put, it is finally a foreign body. So blood tries to get clotted adjacent to the perm cath, even that clotted blood gets infected. So the perm cath is not per se a permanent solution. We might need to change that perm cath frequently. Fistula is good option always because it is a natural. So many times my patients say that fistula bithaya hai. Now see, they imagine that there is some machine inserted into hand. So to clarify, it's not a machine. Basically for fistula creation, 2 blood vessels are joined and 1 artery and 1 vein is joined, so that the vein becomes strong and we can prick in the vein, because we cannot prick in the artery. So 1 needle is inserted in such a direction that it will take blood from the patient towards the dialysis machine, and then another pipe comes, the second needle is inserted in such a way that blood goes into the patient's body, so that the circuit is completed and the function of kidney is done by the machine. So this is how the dialysis occurs. So in pump cath we have two ports. From one port the blood goes out, gets filtered into machine, and then the another port the blood is inserted into patient's body. So this is how dialysis occurs. So we have discussed about the dialysis options like pump cath as the fistula, AV fistula, and we know about the transplant also. So what is the peritoneal dialysis? What is peritoneal dialysis? We are very less aware of this treatment modality in India particularly. What is peritoneal dialysis?
So it's another, like I said, it's a form of dialysis. So like we have hemodialysis where machine is doing the part. Here the body itself, the person's body itself will work as a dialysis machine. So how it happens is we have a layer in the stomach called as peritoneum. So it will cover all the internal organs. Now there are two layers. In between there is some amount of gap or fluid which is there. So what we do in peritoneal dialysis is we put a catheter from the stomach and it goes into that space between the two layers.
Okay.
So here what we try to do is we put a fresh or a clean water, that is dialysis water, inside that space, which will be close to 2 or 2.5 liters, and we let it stay for some time. So the membrane of the body, which is the peritoneal membrane itself, acts as a filter.
Okay.
And whatever organs and blood vessels are inside, waste from those blood vessels will diffuse, or it will come out into the clean water, and the clean water will go inside. So that cleaning process, which is happening from the machine for a 4 hours duration, this has to continue for 6 to 8 hours in a longer duration, and it happens, and the waste water is then taken out from that pipe. New water is put in. So it's a continuous process. It is not like hemodialysis where you have to go to the center, 4 hours dialysis is over. Peritoneal dialysis is where in the early morning they'll put some clean water, then in the afternoon, then in the night, and that stays, and that has to be continuous. Now, why this option and how good is it? So I would say, especially for the rural India where we don't have dialysis centers, it is a very good option because it can be done at home. It can be done by the patient itself. It doesn't require so many assistants working on you. And if a person maintains hygiene, you actually preserve the renal function. We call residual renal function. So your urine output will be staying for a longer time compared to a hemodialysis patient. Where else do we use it? Especially patients who have vascular problems. So who have atherosclerotic disease, or who have poor vessels, who have had pump cath but pump cath infection has happened, or there is stenosis in that area, stenosis, thrombosis. So then we don't have any access for dialysis. So in those patients we can go for peritoneal dialysis, and it's a very good way of dialysis, just that because it's not promoted that much and not covered in so many insurances, that patients are not aware of it, but it's a very good method of dialysis.